Hello, and welcome to this session where we'll look at 12 tips for successfully dispensing foot orthotics. I'd like to thank the association for having me make the presentation. It's good to join you by this forum, and we'll begin. So just by way of introduction and background, my name is Seamus Kennedy. I actually studied mechanical engineering at University College Dublin a long time ago in the last century. That's getting further and further away each time I say it. I became a certified podortist in 1996, and I'm the podortic contributor for the AAOP Edge. I write a quarterly article called Stepping Out. I'm also a board member of the Podortic Foundation. The Podortic Foundation has two missions. One is to provide scholarships for those that might need help to finish podortic education. And secondly, we have some funding for research. The research can extend to anything to do with shoes, orthotics, the foot and ankle in general, biomechanics. It's a pretty broad scope. So if you have any ideas or any plans to do some research in that area, by all means, the Podortic Foundation would like to support that kind of work that's very important for our profession. By way of disclosure, I'm co-owner of Hersco Ortho Labs in Queens, New York, and I'm also a partner in Orthotics USA. That's a 3D printing hub for foot orthotics. Very good. So that's a strange picture to start a presentation with. Some of us, being of a certain age, perhaps those who graduated in the 20th century, might recognize the lineup. So those are the characters in a movie called The Dirty Dozen. So we're going to apply the Dirty Dozen tips to successfully dispensing foot orthotics. I'd like to talk and start this talk by just asking you as a participant, just write down three things, three tips, three ideas that you would share if you were giving this talk. Use that as the basis to build your knowledge, because there are certain things that all of us do every time we dispense foot orthotics or every time we see a patient. And this talk is designed to elicit some other ideas just to build out that approach that we might already have ourselves. Good. Well, having put down a few things on paper, it's important to recognize this talk is fairly practical, simple in a sense. None of the ideas here are going to be earth-shattering, change your life in any way. And yet it's the accumulation of all the simple things. If you put them together, you end up with a very powerful approach to dispensing foot orthotics or to any of the other things that you do in your practices. So it's not really that any one thing will be so different or unique, but applying all the simple rules all of the time makes the difference in the end. All right, let's begin. Tip number one, go with what works. What does that mean? Well, take a look at the orthotic in the picture there. What do we see? This was an orthotic that ended up in the lab, and we were doing a refurbishment of it. So what do we notice just by looking at the picture? Well, immediately from the top cover in the lower section of the photograph, you can see it's extremely well worn. So obviously we know one thing, the patient wore it, and that's not always the case with foot orthotics. So it's a well-worn device, so obviously they liked it. And we can see the shell in the upper part of the picture. It's essentially intact. It's still providing the controls that the patient needs. There's no cracks or anything like that. It's a thermoplastic material. So this device has served the patient well and will continue to do so. So we're going with what works. We're not going to change anything about it. We're just going to refurbish it so the patient can continue to wear it and get the benefit from it. There was a saying by a podiatrist, Sheldon Langer. He was the Sheldon Langer who started Langer Labs with Dr. Justin Wernick back in the early 1970s. He used to say, don't buy a headache. And by that, he meant if something is working, stick with it. Don't change it. There's no need to change the world, especially if the patient is getting the benefit that they seek from the device. Now, it turns out that this is not just practical, there's actually a scientific idea behind this. So there's been a newer theory of biomechanics that's been formulated in the last 10 years or so. It was work done by Dr. BEng, a Canadian biomechanist. And through his work, which has been a little controversial, he developed some new ideas or paradigms, as they call them. One is referred to as muscle tuning, and that involves the body's response to vibration, meaning the body is quite sensitive to vibration and uses the muscles in part to dampen those vibrations. So when we take a step, when we run, we try to minimize the vibration of the impact itself. So our body works in a certain way. A second idea that he developed is called preferred movement path. And that simply recognizes that each individual has their own way of walking. They have the learned mode of ambulation. So we tend to walk a certain way for a number of reasons that is unique to each of us. So for example, you might see a patient ambulate in what appears to be a slightly awkward gait, but that will work for the patient, perhaps because of joint range of motion, perhaps because of ligament flexibility. It might also be because of pain. They might be avoiding pain. It might also be because that's more efficient for them metabolically. But the sum total of all those things, pain avoidance, available range of motion, strength, and so on and so forth, will determine their preferred movement path. And it's important for us to recognize that when we see a patient. So sometimes we might see what we might comically call a crooked patient, although there is no such thing. But in looking at that patient, we might think, oh, I can straighten them up. But that might be a mistake because we want to work within their preferred movement path. So we certainly want to provide devices, foot orthotics, AFOs, and so on and so forth, that will help the patient to ambulate better, that will decrease their pain, that will prevent joint destruction. So yes, our orthotics and AFOs should do that, but we need to do it within what's available to them in terms of their positioning, their function, and what they're comfortable with. So go with what works means when you see a device, whether it be a foot orthotic or an AFO, if it's working for the patient, understand that there's a reason behind that and stay within those limits. Certainly make adjustments, but don't overly correct. So these ideas are covered in BEng's book, The Biomechanics of Sports Shoes. Again, it was a little controversial and not all the experts in the field immediately accepted it. If you don't want to read the book, there's an article on our website exploring a new paradigm in biomechanics that gives a summary of some of the points in the book itself, but it's well worth investigating. Okay, tip number 2, test, test, test. Well, what does that mean? If you have a patient that they come in and they have a prescription for a foot orthotic, if they haven't had a foot orthotic before, you'll obviously read the prescription, you'll do your biomechanical evaluation, but then you'll need to decide, are you going to make them a functional device or an accommodative? Are you going to make it semi-rigid or rigid? You may not be sure, and you may have a lot of leeway in designing the device if the prescription is vague. So I advocate testing something with the patient while they're in your office. Have some good prefabs available. Have a range of orthotics sized out, size 7, size 8, size 9, and just slip it into the shoe. You can have them in semi-rigid, you can have them in rigid, or you might have them in foams. Going by our first tip, which was go with what works, and this idea of preferred movement path, by having test orthotics available, even if they're not perfect, the patient will be quickly able to give you feedback and tell you, yes, that feels good, I like this, or no way, I can't wear that, that's way too hard for me, it really hurts in this particular spot. So with a little bit of investment in some test orthotics, you can quickly determine the right direction in which to take the patient whilst fulfilling the requirements of the prescription. There are other ways to pre-test as well. What might they be? And I'm sure some of us do these every single day. Take an example where you need to put an accommodation into the orthotic, or the patient has an orthotic, perhaps it's not working for them, in which case I would imagine they must have gotten the orthotic from some other practitioner, but now they've come to you to seek some help. The orthotic may be reasonable, it might be okay, but it may not be solving their problem. So again, test. If you want to enhance the orthotic, make a change to the existing orthotic. Don't start with a clean piece of paper unless you feel the current device is a disaster. So doctors are fond of using felted foam. So in the picture on the left there, we see there's what appears to be a sesamoid pad type dispersion. Just apply it to the patient's foot, have them wear the existing orthotic, and see, does it feel better? They can often tell you fairly quickly if it's going to be making a difference or not. Another good example is using heel lifts or cork wedges. So if you want to post an orthotic, just quickly create one out of crepe or cork and try it inside the shoe on the spot. That will lead you in the right direction before you've made an investment of time and money into an orthotic that you're not sure if you're going to have the correct outcome with. So testing is a wonderful thing to do. Number 3, again, these seem so obvious, it's hardly worth discussing them. And yet the number of prescriptions that arrive in a lab that don't have pertinent details and information would surprise you. So record the patient details. Be meticulous here. So you always want to obviously have the patient's prescription. You want to understand the diagnosis, but then fill out the patient's profile. Which data do you consider most important? So that's the annoying information box at the top of every prescription form. And it's there for a reason. It helps a lot understanding the final design of the orthotic. Now, I like this picture here. These might have been patients that you saw yesterday, him and her. They came in for some orthotics. It wouldn't be surprising if they were diabetics, let's say. We see a lot of those in our practice. And what's the first thing you notice? I'm a kind of a foot junkie. So when I see a picture like this, I look at their gait. And it appears certainly that he has some pes plano valgus, certainly some heel valgus. The second thing I notice is he was in my office yesterday and he's not wearing my orthotic. And we asked them not to walk barefoot, but this is what happens. In looking at those patients, if they were in the lab, what details would I like to record? The 3 most important ones, as far as I'm concerned, is the patient's weight. This makes a big difference to the final design of the orthotic. So the patient's weight will determine the durometer and the thickness of the material that you choose. So even if you know you're going to have a thermoplastic device, the lab will need the patient weight to determine which thickness. Should it be 3 mil subortholin or 4 mil subortholin, or whatever the choices might be. Secondly, it's good to know the patient's lifestyle. You know, is it just a general orthotic for everyday wear? Is it sport specific? Are they running the marathon? Are they playing sports on a court like basketball or badminton or volleyball or something like that? So we need to know what it's being used for. And thirdly, the shoe style, very important. What kind of shoes are going into? Is it a shoe with a removable inlay, a sneaker, an extra depth shoe? Is it a tight fitting shoe? Is it a narrow shoe? Is it a woman's dress shoe? The orthotic, you can still make the same orthotic, a thermoplastic for plantar fasciitis, but you'll choose a different material and you'll machine it differently based on the shoes that it's going into. So these become what I consider the 3 most important pieces of information in the patient profile, besides the diagnosis and the prescription, obviously. Fourthly, now we've heard this any number of times, but it's very important to take a good cast. So on the left, we have a diagram showing the plaster slipper cast technique. So that comes from the root subtalar neutral theory of biomechanics. And that's the traditional way to get the best cast for a patient. And you can do it by loading the foot, holding the calcaneus in neutral, and letting the plaster set. We don't always have time for that, number one. Number two, not everyone's technique is quite so good. So we have gotten casts from doctors. They followed the theory, so they've done that plaster slipper cast, but the result is terrible. The plaster is too wet, it collapses. So having put all the time into it, the net result is not great anyway. So know your limitations in taking a cast. Impression foams are good for the majority of cases. I know if I was at a biomechanics lecture or I was with a room full of podiatrists, we could get into arguments about this. But a good semi-weight bearing impression foam often presents the best representation of the foot to make the majority of orthotics. There are times plaster slipper casts are better, especially in cases where you want to be very accurate in terms of biomechanics, where you're dealing with athletes or sports patients. But both of those methods are now being replaced by the scanners that are available. And there's all sorts of systems out there. Again, taking the scan correctly takes a little bit of practice. There's an art to it. The foot should still be brought to the neutral position, and some slight loading on the forefoot helps. But regardless, the point of this slide is to say, take a good cast. That famous saying in computer programming, garbage in, garbage out. The technician can only make as good an orthotic as he receives in the actual cast itself. But more importantly, know your own limitations. Don't try to do it the theoretically best way if you know the technique is not what it should be. And a caveat to people in the O&P community is be careful with fiberglass. It doesn't really have the subtle contours that we need to make accurate biomechanically controlling foot orthotics. So use it sparingly, I shall say. Plaster slipper cast is good if your technique is good, and they're good for functional foot orthoses. The impression foam is very good for accommodative molds, and in particular, if you're trying to offload bony prominences or a specific spot on the foot, the impression foam can be very good because it can capture the exact location, and you can even do it semi-weight bearing or weight bearing, where you need to get the position right when the patient is in ambulation. It's not so important when they're non-weight bearing. And finally, the scanning can incorporate both of these techniques. Point number 5, take a tracing. Well, what should you trace? In this case here, we see Nerys, one of our technicians. She's tracing the insole of the existing shoe. So take the sock liner out of the sneaker and trace it. Send it to the lab, and then they'll trim the orthotic to the exact shape. You won't even need a pair of scissors when you're dispensing. You'll just be able to slip it into the shoe. Send the shoe, then the orthotic will be fit to the shoe. You won't even have to take the orthotics out of the bag and put them in the shoe. So all of these things make for the perfect fit. What else could you trace? Well, there are other things. Now, tracing seems to be obvious. You just take the inside out and trace it. But there are other things you could send to help with the final shape of the orthotic. And I would also say, again, harken back to slide number 1, which was, what was it? Oh yeah, I remember. Go with what works. If the patient has an existing orthotic that they love and that they won't give up because they love it so much because they don't trust the postal service, trace the existing orthotic, and then the lab can machine the actual shell and the final top cover lengths to the existing device that they love so much. But there are other things you can send to the lab. This was a case that we received at one time. They sent us an impression foam plus the picture plus the x-rays, which were very helpful. I asked what was the initial problem for the patient. They said, oh, it was auto amputation. And I said, oh my God, auto amputation. Well, did this happen in a car accident? They said, no. I said, auto amputation. Did they do it to themselves? They said, no. Auto amputation. was the spontaneous shedding of the distal aspect of the second and third phalanx. So it auto amputated. So it didn't look so clear in the impression foam. And we just assumed the toe was misplaced, or it might have been a hammer toe. But when we saw the photograph, we realized what was missing. And when we saw the X-ray, we could see exactly what was missing. So it helped us to place the toe filler correctly for the patient. This helps in other ways, because sometimes you might think the impression foam or the cast is not great. So in a case like this, we would call the practitioner and say, is the toe really in that valgus type position? Or is it really just there when the cast was taken? Can it be moved back? Meaning, could we have the filler butt against the lateral side of the hallux and without causing an irritation? And in this case, they said, yes, we could. So we were able to straighten the toe a little bit when we made the device here, understanding the diagnosis and seeing the osseous configuration of the foot itself. So take a tracing. Send as much information as you can to the technician. Send them too much information. Send them cookies, whatever you want. That's no problem. All gifts gratefully received. But what tends to happen more often is we don't send enough information. We don't fill out the patient's weight or their lifestyle. We don't send a tracing. So we just get a cast, and it might say sports orthotics, which is fair enough. Then the lab will make sports orthotics. But a little more information could really fill out the design. Here's one of my favorites. Again, these are so obvious, it's hardly worth having this talk. And yet, if you begin to do all these things every single time you see a patient, it makes such a huge difference. No surprises, show samples. Have a few samples in the waiting room, have a few samples in the lab. You can show it to the patient. Many patients don't know what a foot orthotic is. They will recognize an insole that they saw in the pharmacy, but they'll need to see and feel what you're going to make for them, especially if it's something for a diabetic. It has a lot more thickness. It's a lot fuller than what they might be used to, or a rigid sports orthotic for somebody who's a runner. They would like to see what it's going to look like. Tell them, don't buy your new pair of shoes until you get the orthotics. Get the orthotic first, then buy the new running shoes. So you can show them the device. You can explain your rationale for the material choices. You want to give them a cork device, which you see on the left there. It's firm, it will support them, and yet it's not rigid. Or maybe they're wearing dress shoes. They wear loafers to work. So you want to give them a very thin device. You give them a carboplast device, which you see on the right-hand side there. It's thin and it's hard. Some people might initially feel, I don't want a hard orthotic, but you can explain to them they get the best control and the least amount of room inside the shoe. Some devices are full length. That way the entire plantar foot is protected and areas of pressure are dispersed. Other devices are shorter. They're only to the sulcus or to the met heads. In that way, there's more room for the toes inside the shoe. You can explain that to them. We had a case one time where a woman came in for a pair of orthotics, and we showed her what we would make her, and she said, I don't want that one, I want this one. She picked a different one. And we said, why do you want that one? And she said, because my friend has a pair just like that, and she's very happy with them. And we said, but your friend has a different foot problem. So let me explain to you why you need this one over here. And it was resolved happily in the end. You'll be glad to know. But patient education can be an important aspect of their accepting of the device. Design for adjustability. As orthotists and podortists, we're often dispensing these devices in our labs where we have access to some equipment. So knowing that that's available to us, when you make the design of the orthotic, you should consider, okay, I may have to make an adjustment here. It might need to be tweaked the day I dispense it, or it might need to be adjusted 2 weeks after the patient has broken it in. So again, in the pictures here on the left-hand side, we have a cork device with a plasto top cover. The cork is not covered on the bottom. So if you need to change the posting in the rear foot, you can easily do it. If you need to lower the arch, you could quite easily sand it down ever so slightly. On the right-hand side, we have a dress orthotic, but it's covered top and bottom. So if we need to get in there to make an adjustment, we're going to have to peel off either the top cover or the bottom cover. If we work on the suede on the bottom, it often is very hard to put it back and keep it looking the same way. Again, it's not to say that you should or should not choose any of these devices, but just if you feel there's going to be extra work involved, design for adjustability. Keep in mind, okay, I may need to heat it up and just change the arch contour ever so slightly. In that case, it needs to be a thermoplastic device. If you choose a carbon graphite, there's no spot heating that and changing any arch contour. So just in general, carbon graphites would be more difficult to adjust. Suede bottoms are more difficult to open. If you have PPT or Poron sandwiched in there and you use acetone, it will disintegrate. So the design materials shouldn't limit what we want to do for the patient. We always want to give them the best device and give them the one that they need and follow the prescription, of course. But if we have some choices, keep that adjustability in mind. Now, I don't know what time it is where you are, but that sandwich always looks appetizing to me. That's a real burger. That was a McDonald's burger in Japan. It was called the Mega Tamago. And at 846 calories, I'm surprised it's only 846 calories. Take a look. There's some bacon peeking out from the side there. We might end this lecture early so we can hit the snack bar. Now, why is that in the talk, other than trying to be cruel? Well, consider this. We often try and build our orthotics up and we want to put everything in there because we're so excited about what we can do for the patient. So this is not an unusual patient. You know, you could have a patient, you do a biomechanical eval, and you will notice along various gradations some of these things. Okay, the patient presents, they have pes planus, not unusual. They're complaining of metatarsalgia, subsecond. There appears to be some functional hallux limitus. There's a slight leg length discrepancy. And you notice a mild Morton's toe. The mild Morton's toe, which is the longer second digit protruding beyond the first, beyond the hallux, might be precipitating in some way the metatarsalgia. So some of these things are interrelated in your findings. But where do you begin? The danger is you start to build the megatamago. You see so many things, you get so excited, and you remember the last biomechanics lecture you were at. You're like, okay, I'm going to correct the pes planus. I know what to do for the metatarsalgia. Functional hallux limitus, we'll do a cutout for that. I'll put in a lift for the leg length discrepancy. Now you've built up a very complex sandwich for your patient. But is that the best way to go? Where do you begin? Well, I start with a very simple question if I'm not sure what to do. I say, why did you go and see the doctor in the first place? That is what they want solved. So the principle is less is better. Address the primary complaint. You might have other findings in your biomechanical evaluation. You can get to those later. You want to do that for two reasons. One, you don't want to have such a huge built-up orthotic with all these different bells and whistles inside the shoe because it won't fit. But secondly, you want to solve the issues one at a time. So in the example that I gave, let's say the real issue and the reason the patient went to see the physician, which is vital, because that's what motivated him to take some action, was metatarsalgia. So address that first. So make a good orthotic to address the metatarsalgia, which might include a couple of things, some arch support, a metatarsal pad, perhaps a heel lift. And let that be sufficient unto itself at the beginning. If you see a leg length discrepancy, you might want to suggest to the patient, once we resolve the metatarsalgia, you might benefit from some sort of a lift inside your shoe or outside your shoe. But let's not do that just yet, because you want to see if the orthotic that you dispense helps with the metatarsalgia. If it does, you've made progress. If it doesn't, stay on the metatarsalgia until it's resolved or abated to some degree. Then proceed with further enhancements. Okay, so now point number 9, post carefully. There are reasons to be cautious with extrinsic posts. So I'll give you 3 reasons in particular. I'm sure you can guess the first one. Now, this picture shows a sports orthotic with a rear foot post, but a hefty forefoot post. And I'm going to focus particularly on the forefoot posting here. The number 1 reason you want to be careful with posting orthotics, rear foot or forefoot, but especially in the forefoot, is shoe fit. And this goes back to point number 3 earlier when we looked at the patient's weight, their lifestyle, and their shoe style. Add posting if they need it, add posting if it's directed on the prescription, but don't over post if you're not sure that it's needed, because you'll be taking up valuable space inside the shoe. And often patients will be given a good evaluation, they'll receive a fine orthotic, but if it doesn't fit inside their shoe style or their lifestyle, they won't wear it, so they can't get the benefit from it. So it's very important to use your posting judiciously and consider the shoe. 2 other reasons to be careful with posting have to do with some biomechanics. So the first one has to do with the orientation of the subtalar joint axis, which is basically the axis about which the foot rotates. The foot and the calcaneus rotate underneath the talus bone. So that's an oblique axis, and we can see it represented in the diagram here. Without getting too far into the biomechanics of it, the orientation of that axis across the midline of the foot, or at an angle to the midline of the foot, changes for each individual. So if somebody has a pes planus or a pes planovalgus, often the orientation of the subtalar joint axis will move rather extremely medial to the midline of the foot, which we're seeing here in the top picture of the foot. So quite simply, when you're posting an orthotic to control a pes planus, if the subtalar joint axis has medially deviated, as we see here, the posting needs to go on the medial side of that axis, meaning that's why we do rear foot posting and why we provide orthotics with an arch raise, because they're working on the medial side of that axis. If we put posting that ends up being on the lateral side of that axis, we're actually making the situation worse. So using forefoot posting can be detrimental, can almost have the opposite effect if we're not aware of the orientation of that axis. And then there's a third reason to be careful with posting, and that has to do with the windlass mechanism. Again, this refers to posting in the forefoot. So the windlass mechanism is something we can probably know already, but you could certainly Google if you need to. And there are articles on our website on biomechanics principles that will discuss the windlass mechanism. Essentially, the windlass mechanism is the effect of the foot dorsiflexing or moving over the hallux when it's plantigrade. So it's that motion there after a heel rise occurs. So what's happening is you're pulling the plantar fascia tighter, and as a result, making the foot a rigid lever. What it requires for that to occur is range of motion at the first MPJ. There needs to be plenty of range of motion there. So it requires unrestricted motion of the first MPJ. So the hallux is actually dorsiflexing on the proximal foot. Essentially, what's happening is the hallux stays flat on the ground and the proximal foot is moving over the first MPJ later in the gait cycle. But we need to make sure that that motion is available and not restricted. So the windlass mechanism is very important for maintaining the arch and the stability. The orthotic needs to help the windlass mechanism function. So an orthotic will help that by actually raising the arch which will plantar flex the first metatarsal, and it will allow first MPJ motion. However, if you put material underneath the first MPJ and you dorsiflex the first MPJ and the first metatarsal itself, you will block the motion that can naturally occur at that joint. So you need to be very careful not to put a 4-foot post there that's going to block motion of the first MPJ. Have patience with your patient. Make sure that you give every patient a written break-in protocol so they can follow these simple step-by-step guidelines. It will save you having to explain it to them several times. It might save a couple of phone calls, and it will mean that they accept their orthotic in a safe, effective manner. And you hopefully then won't hear from them for a couple of weeks as they go through the protocol. One of the great fears about giving a patient an orthotic is that they'll have instant feedback for you. They'll tell you immediately, I don't like it here, it hurts there, this is strange, left is different to right. That might be what they're feeling in the moment, but with a little bit of time, some of that would settle. Perhaps the orthotic is not right for them, but it's better to wait a week, 2 weeks, so they can really isolate and focus and tell you specifically what the issue is. I feel the rim of the heel cup. Then you know you have to make an adjustment there. If you start making changes too soon, again, you'll be chasing yourself trying to figure out, okay, was it the heel cup? Was it the metatarsal pad? Was it the shoe fit? So give them a written break-in protocol and then have them follow that meticulously for a couple of weeks before you begin to get into changing the orthotic too much. This would seem pretty obvious. Get some equipment. If you're dispensing orthotics in your own lab, you often have a lot of the new clinics, or we're seeing patients in their home. Get some portable pieces of equipment. So the three famous ones are a heat gun, some sort of a sander if you can. A couple of practitioners have sanders in their vans, believe it or not. A Dremel is a tremendous device. It can do all sorts of wonders. They used to say the three great pieces of equipment for fixing all problems were super glue, WD-40, and duct tape. And you can bring those as well if you want. But having access to equipment can make a big difference. And here's a final one. Dispensing foot orthotics. Know your expertise. Maybe you've become very good with sports orthotics and with athletes, and you take care of a lot of teams in your locality. That's a very specific specialty, and one that you can become well known for and do extremely well in. Develop that. Understand your materials, understand your patients, and then be able to refer other patients that are not in your expertise to somebody else. Perhaps you don't spend so much time with children, but you know a pediatric specialist. That way you can focus on what you do best and be the very best at it. You know, there are subspecialties for sports, for pediatrics, and finally, just another obvious tip, call your lab. If you don't know what to do, the labs see these issues, these problems, these prescriptions day in and day out. Often they'll be able to help you with a particular design or a material choice or the placement of padding or whatever. Send them photographs, text them. The lab, whether it's your own in-house lab or an outside center fab that you're using, should be an extension of your practice and should be able to help you through all of the different challenges that you face on a daily basis. So thanks very much for attending the talk. There was nothing particularly earth-shattering in those 12 tips. your approach to treating patients who need foot orthotics, and I would also suggest your success rate and patient satisfaction also to make you a more potent practitioner. All of this is discussed and written in an article on the website, Successfully Dispensing Foot Orthotics, 12 Tips for Better Outcomes. And if you have any questions or specific follow-up requirements, feel free to email me or give the lab a call. Thank you very much once again. Take care. So finally, tip number 12, know your expertise. There are many different specialties that we can focus on in our careers. For example, pediatrics. We might be in wound care, diabetic care. Perhaps we're working with athletes, sports. Within each of those, we develop a kind of a specialty and a following, and we really learn to hone our skills for that particular patient group. Sometimes it's best not to cross into a different patient group if you don't have the experience. Whilst we would all be capable of taking care of those patients, it might slow you down in your normal practice. So if you're a sports specialist who really works with athletes and athletic teams in your locality, if all of a sudden you get a referral for somebody with a charcot foot and they need a wound healing, perhaps refer that to someone else in your practice or in your area. But it's good to develop a specialty, invest in it, make that your expertise. Finally, bonus tip, call the lab or call the technicians that you're working with if it's an in-house lab. You will often get a further insight or a different point of view by talking to them. Don't forget, those technicians, they work with foot orthotics specifically day in and day out. You might have knowledge of AFOs, of wound healing, of fracture care, but their specialty is working with foot orthotics. Learn to rely on them, seek their knowledge in trying to solve some of the specific problems that you can come across in your day-to-day activities. Very good. So thank you for attending the talk. Hopefully you've picked up some ideas here, and it's just brought you a couple of other different points of view when you're seeing your foot orthotic patients. None of the things here are particularly earth-shattering, groundbreaking, but put together, if you do each and every one of these, every time you see a patient, you'll look like a hero. Your patients will thank you for it. Ultimately, it's about making the patients better, patient satisfaction, and providing the healing and the therapy that they need to have active, healthy lifestyles. And hopefully this will help. All that we've spoken about here is covered in an article, Successfully Dispensing Foot Orthotics, 12 Tips for Better Outcomes. You can get that on our website. And finally, I'm always happy to answer questions or help in any way that I can. Feel free to email me or call the lab. Thank you once again. Good luck.